And the first professor I want to introduce you to, and it's my pleasure to introduce you to, is Dr. Dorothy Patton. Dr. Patton is a professor in obstetrics and gynecology and is an adjunct professor in biological structure and ophthalmology at the School of Medicine here at the University of Washington. She earned her Ph.D. here at the University of Washington in biological structure, and her research activities are extraordinary, and they include studies in the pathogenesis and treatment and prevention of chlamydial infections, which you may or may not be aware of are still an ever-increasing problem, particularly in some of our youth within America. So without further ado, please welcome Dr. Dorothy Patton.
Thank you so much, and good evening to all of you. One crucial element of maternal and child health that has sorely been neglected is the prevention and treatment of sexually transmitted diseases. Tonight, I'm going to spend a few minutes talking with you about chlamydia, because what you don't know can hurt you. Chlamydia is a common sexually transmitted disease. It is caused by the bacterium named Chlamydia trachomatis. The symptoms of the disease may be mild or completely absent. In the case where the symptoms are absent, it is called a silent disease. Now, the transmission electron micrograph that you see here on the bottom of this slide shows a mature chlamydial inclusion growing inside of an epithelial cell. And you'll notice that the success of chlamydia is dependent upon two alternating cell types, the elementary body shown here and the reticulate body down here on the bottom, the larger particle. And we'll talk more about those in a few minutes. Now, the highest incidence of urogenital tract infections caused by chlamydia are in teens and young adults. The majority of these infections are asymptomatic. They often go undetected and frequently untreated. But despite the lack of symptoms, an unrecognized infection of the lower genital tract of women may actually progress into the upper reproductive tract, where it will cause irreversible damage of the fallopian tube. It may cause pelvic inflammatory disease and even tubal infertility. Now, this is a schematic diagram of what we know of the life cycle of Chlamydia trachomatis. And these observations are actually based on in vitro cell culture studies. And as you can see, the life cycle is dependent upon two particles, the elementary body and the reticulate body. The elementary body is the extracellular cell for the life cycle, and the reticulate body lives in the intracellular environment. Now, the highly infectious elementary body attaches itself to the cell membrane of the epithelial cell, and perhaps it attaches to a cell receptor. To date, such a receptor has not been identified. But suffice it to say, the highly infectious elementary body is internalized into the epithelial cell, and it then goes through a reorganization or transformation and becomes the non-infectious reticulate body. This particle actually is active metabolically, and it grows and divides for several hours by binary fission, up to maybe 40 hours. Before, again, there's another transformation or reorganization, and this non-infectious particle then becomes the highly infectious EB, or elementary body, and that large inclusion that I showed you actually ruptures, and each one of these infectious particles then must go and find a new epithelial cell to infect in order to continue the life cycle. Now, I'm about to show you a short segment of film taken in my research laboratory. We will first look at healthy epithelial cells and then chlamydial infections. The healthy epithelial cell, as shown here, contains a large cytoplasmic compartment, and the nucleus is the largest organelle seen in the cell. Also notice that within the cytoplasm there are numerous mitochondria. Now, here we see in the highlighted cell on the center of the screen the nucleus and two chlamydial inclusions, one here and a larger one here. The inclusion that you see here on the top is going to migrate along the surface of the nucleus it will make contact with this lower inclusion, and the two of them will actually fuse together, forming one large chlamydial inclusion, and the infection continues. Now, the mechanism of this fusion is not known. Another day later now, the chlamydial inclusion has grown quite dramatically. You'll note that the large cytoplasmic compartment that we saw earlier in the healthy cell is now completely filled by the chlamydial inclusion. Notice, too, that the prominent nucleus has now been pushed over to a very small portion of the cell. And the inclusion now is growing, and in this segment, you will finally see a mature chlamydial inclusion. It's rotating in a clockwise fashion in the epithelial cell. Notice that it's filled with these highly infectious elementary bodies. Also, we note that there is a rippling effect occurring at the edge of the inclusion. The inclusion is now rounding up, and a rupture event occurs. And as you saw with that mini volcanic explosion, all of those elementary bodies or infectious particles must find another cell to infect. This slide indicates the worldwide prevalence of chlamydial infection, 89 million infections per year. Here in the United States, approximately 3 million cases of chlamydia per year at an annual cost of about $2.4 billion. And the cost of this is primarily associated with the infection and the reproductive complications associated with female reproductive tract. Approximately 600,000 women develop pelvic inflammatory disease each year, and of that 600,000, 50,000 become infertile. Chlamydial infections are also known to be a cofactor with the transmission of HIV. And locally, what about the state of Washington and King County? Do we have chlamydial infections? It was reported recently in 2003 that over 5,000 new cases of chlamydia were documented in King County, and statewide over 17,000 cases. Now, as I've said, chlamydia is a sexually transmitted disease, and it can be transmitted not only through vaginal intercourse, but also through anal intercourse or oral sex. And it can be transmitted from an infected mother to her baby during vaginal childbirth. Who's at risk for getting a chlamydial infection? Well, the highest incidence of chlamydial infections are in young people between the ages of 15 and 24, young teens, and young adults. Also, people who are sexually active, who have a new partner or partners, or multiple sex partners, or if you're non-married. In addition, if you've had a gonococcal infection or previous chlamydial infection, you are at higher risk for chlamydia infections. Not only being young age, as is shown here, especially the 15 to 24-year-old group, but also the female gender is at higher risk for chlamydial infections. And this may partially be due to physiological differences between males and females. About 75% of women and 50% of men with chlamydia have no symptoms of chlamydial infection. This means that the majority of the cases are actually undetected and unreported. However, if symptoms are present, they may include in women unusual vaginal discharge, pain with intercourse or bleeding afterward, bleeding between menstrual periods, lower abdominal, pelvic, or back pain. And in men, there may be a discharge from the penis, burning with urination, and swollen or even painful testicles have been reported. Chlamydia trachomatis infections have a profound impact on female reproduction. So before I talk about what happens during chlamydial infection, I want to first review with you normal female reproduction. And this is a schematic slide then that shows the normal female reproductive tract, the cervix, uterus, fallopian tube, ovary. Now, in the case of normal female reproductive function, the egg is ovulated from the ovary and picked up by the fimbriated end of the fallopian tube. And then it is transported through the fallopian tube, and if intercourse had occurred, fertilization may be an outcome. Now, if fertilization occurs, it happens here in the distal part of the fallopian tube. It does not happen here in the uterus. So the fertilized ovum then spends another 10 days approximately being transported through the remainder of the fallopian tube to finally be brought to the endometrial cavity for safe implantation. Now, in the case of being exposed to chlamydial infection, the first area exposed is that of the cervix. The infection proceeds through the endocervical canal. The infection is now migrating then from the lower reproductive tract into the upper reproductive tract through the endometrium, moving into the fallopian tubes. And as it's moving through the tubes, it's infecting these adjacent epithelial cells one by one. And as this is happening, not only is the disease migrating into the upper part of the reproductive tract, but there's also extensive scarring and fibrosis that's occurring here in the distal end of the fallopian tube. Here again we see complications that result from chlamydial infection, but a reminder, the normal fallopian tube shown here, this is a low magnification scanning electron micrograph, and here you see the longitudinally oriented mucosal folds that line the fallopian tube. And on higher magnification, you can appreciate then that there are two types of epithelial cells. One is ciliated, they're these hair-like structures that you see here, and it's this cell that's primarily responsible for assisting in the transport of the ovum through the fallopian tube. The large bulbous or dome-shaped cell that we see here is the secretory epithelial cell, and this is actually the cell that will become infected by the chlamydia. Now here, with this patient, she has silent chlamydial PID. She had no symptoms, but immediately you recognize that the normal tubal architecture that we have here is completely absent. And when we look at the little bit of mucosal fold that is present, you'll note that there are both ciliated and secretory cells, but the number of cilia atop this cell might be 10 or 12, as compared to the normal cell over here, which had 250 or 300 cilia atop each cell. You can also see many cracks and crevices between the secretory epithelial cells, and note too the microvillus projections on the surface of the secretory cell have become thickened and clumped. When we look more grossly at these tissues, again, this is the normal fallopian tube and the fimbriated end of the tube, and then we look at a patient who's had chlamydial PID, you can see that there is, no longer do we recognize the fimbriated end of the tube. In fact, it has been pulled inside of the tube, and now this tube is glued shut. So the patient is actually infertile because the tube is blocked. We also know that there is a 7 to 10-fold increase in the rate of ectopic pregnancies following chlamydial infection. This is a normal fimbria and fallopian tube. Here we have a fallopian tube that contains an ectopic gestation. Now think back just a moment ago to that slide where we saw the scanning electron micrograph with the changes in the mucosal architecture, all the cracks and crevices. And this makes it easier to understand how a fertilized ovum could actually get trapped and implant here in the fallopian tube and grow, rather than being successfully transported to the endometrium. And this slide simply summarizes then the fact that women do bear the burden for chlamydial infections in terms of our reproductive tract. Here we see the untreated effects of untreated chlamydial infection. First in the lower reproductive tract or at the level of the cervix, the cervicitis has developed. There's a mucopurulent discharge, and the epithelial cells are inflamed or friable. That is, if you touch them with a cotton tip swab, they will bleed. The infection then is migrating into the upper tract, causing scarring and fibrosis or PID. Again, we see the blocked tube or infertility, the ectopic implantation, And lastly, if pregnant, infected, and not treated, your infant can develop conjunctivitis or even pneumonia by being born through an infected birth canal. So how do we diagnose chlamydial infection? Well, there are numerous laboratory tests out there, and one of the newest is a urine screening test that actually utilizes PCR or other DNA amplification methodologies. Or we can collect a swab of tissue or cells, either from the endocervical canal from the woman or a urethral swab from men. These swabs, the cells that are collected in these swabs are then put into cell culture, and the chlamydia will grow. And they can be stained either by a supravital stain here, such as Giemsa, so the inclusion itself will appear bluish, or by a fluorescein conjugated monoclonal antibody to chlamydia. And in that case, the inclusions appear apple green, as shown here. These are the most currently published treatment guidelines for chlamydial infection, published in 2002 from the Centers for Disease Control. The first line of therapy now recommended is a single dose of azithromycin or a 1-week course of doxycycline taken twice a day. Now, just to remind you, in the blue box we see the untreated chlamydial infection, and in the red box we see a single dose of azithromycin. Notice that the inclusion is actually just a small ghost-like structure after the azithromycin treatment. We do not see the presence of the highly infectious elementary bodies. And these are other alternative treatment regimens for chlamydia. Notice that they are all 7 days in length and multiple dosing throughout the day. Well, how can we prevent chlamydial infections? Well, clearly, the surest way is to abstain from sexual activity. However, if you are sexually active, there are ways to reduce the risk of acquiring chlamydial infection. First, proper and consistent use of a condom. And now, chlamydia screening is recommended annually for all sexually active women 25 years of age and younger. There's also annual screening for older women who have high risk factors, including new or multiple partners, and all pregnant women should be screened for chlamydial infection. If you are sexually active and you do note mucopurulent discharge, pain, certainly stop having sexual activity, consult with a healthcare provider, and by all means, you must communicate with your partner or partners because it is a sexually transmitted disease. All persons involved need to be treated. So how can we prevent chlamydia in the future? We hope to have a vaccine for chlamydia or a topical microbicide product. Topical microbicide products are products that we hope will reduce or prevent STD transmission, and not just chlamydial infections, but also HIV, gonorrhea, syphilis, trichomonas, and so on. Topical microbicides are planned to be applied vaginally or rectally before having sex, and will primarily be a woman-controlled preventative device. And they are likely to be developed before a vaccine. Currently, there are about 60 products that are being developed as topical microbicides. Of that 60, 18 have had a safety profile in preclinical studies, and 5 of those 18 are currently in various stages of clinical trial. Here we see why topical microbicides are needed. First and foremost, not all women have the right to say no to sex. In addition, current prevention methods require partner cooperation. Too many men refuse to use a condom, and often inconsistent or improper use of condoms occurs. Not so long ago, in 2003, the CDC did a youth risk behavioral survey, and in that survey they found out that 31% of all sexually active high school students did not use a condom at last sexual intercourse. And I'd like to close with why is chlamydia so hard to control? Well, clearly the diagnosis is difficult, and it is difficult because of the asymptomatic nature of the disease and also because it does infect the young age group. We also know that recurrent infection is common even after completion of an appropriate antimicrobial for chlamydial infection. And lastly, as I've just discussed with you, effective prevention for sexually active people is currently not available. Thank you.
Our next presenter is Dr. Thomas Mac Hooton, and I remember Mac fondly from my days also in the Harborview Medical Center Emergency Department, where he would graciously take morning report, which is what happens after a busy night shift in the emergency department. You would present the cases you had on the night before and have your care of the patients critiqued. And Mac, you're always kind and gracious and a great instructor throughout all those events, and I'm grateful. Dr. Hooton is professor, Division of Allergy and Infectious Diseases in the Department of Medicine, School of Medicine, and he's the medical director of the Harborview Medical Center AIDS Clinic at Madison Clinic. He's a chair of the University of Washington Pharmacy and Therapeutics Subcommittee on Infectious Diseases, and he's also chair of the Harborview Infection Control Committee. He earned his M.D. From the University of Texas Southwestern Medical School, Dallas, and his research interests include urinary tract infections, and I've called Mac a number of times when I've had a problem or a dilemma in that area in the care of patients, as well as clinical studies of antimicrobial resistance and methods to reduce antimicrobial usage, as well as HIV medication compliance. So please welcome Dr. Mac Hooton.
All right, thank you, Terry, very much. Well, thank you for inviting me, and my talk is on HIV. So let's spend a little bit of time talking about epidemiology of HIV, natural history, antiretroviral therapy, a little bit on some of the complications, at least one of the more common complications we see in HIV care, and a little bit on the opportunistic infections that we see and how we manage some of these things in HIV. So how about epidemiology first? Well, I think you probably are aware of the fact that this is one of the major pandemics of history. Flu in 1918 was a major pandemic, of course, and plague back in many years ago was a major epidemic. Well, HIV is too, and it's estimated between 40 and 50 million people currently have HIV infection, and this world map just shows where the cases are concentrated. Around 1 million currently living patients with HIV in North America. The big area, of course, is in sub-Saharan Africa, where a goodly proportion of HIV cases now reside, but Eastern Europe is an area that's growing in terms of numbers, and Southeast Asia. And approximately 20 to 30 million people have died from HIV over the course of this epidemic over the last 2 decades. Well, as of around 2003, these are the estimates as to how many people acquired HIV daily, and globally is estimated to be 14,000 new cases. In Africa, 9,000 new cases, and in North America, around 120 cases per day, times 360 days, around 40,000 new HIV cases per year, and that estimate has been fairly stable over the last few years. This is looking at HIV/AIDS and deaths in King County over the 2 decades of the epidemic, and so bear with me just a minute, but this is the number of cases of HIV infection per year. So HIV is different from AIDS. They're linked, of course, but AIDS is the more advanced state of HIV infection, as defined by either having certain clinical conditions or having an immune system that's compromised to the point that it meets the criteria for AIDS. There was a dramatic increase in the number of HIV-infected cases early, and these are estimates because these were not being reported back in the 80s, but there was a dramatic rise. Remember, there's a several-year lag between acquiring HIV and developing the clinical syndrome of HIV, at least in general. We know from what you've heard about this patient in New York, sometimes they can be very fast, and those are scary type infections, but in most cases it's several years. So these bars show the number of AIDS cases reported, and if you were around in the late 80s in this area or any part of the country, it was quite scary because every time you would see data, there was a dramatic increase in the number of AIDS cases reported in the United States. It was scary. When I became the medical director of the Madison clinic at Harborview in '91, around that time, the number of AIDS cases reported in the United States was doubling every 6 months, and I wasn't quite sure what I was getting into. But luckily, as prevention efforts started paying off and the number of new cases started dropping, several years later, that showed up in a drop in the number of AIDS cases. And then this shows the number of deaths. It was increasing dramatically too. And it started leveling off in here, reflecting the reduction in the number of new cases. And then we had HAART come along. HAART is highly active antiretroviral therapy. It's what we call our potent HIV therapy. And it reduced the number of cases of AIDS and deaths dramatically starting around 1996. Now, what's interesting in King County is still estimated, and it's been fairly stable for years now, 400 to 500 new HIV cases annually. And there's been a little bump in this area and in several parts of the country over the last couple of years in terms of number of new cases. Well, what's the risk of acquiring HIV? You all know that HIV is transmitted through the bloodstream, through needle sticks, sharing of needles, sexual intercourse, and so forth. So what's the risk of acquiring HIV through these methods? So this slide shows the rates of transmission to an uninfected person per 1,000 acts. So 1,000 acts of heterosexual intercourse, around 1 per 1,000, okay? Now, you never know which one it's going to be. It could be the first one, or it could be the last one, but that's an estimate. Men who have sex with men intercourse, 1 to 17, and if the man has receptive anal intercourse, it's the highest risk. Estimates here, 17 per 1,000. If you get stuck with a needle from an HIV-infected source, the risk is around 3 per 1,000. Now, that's modified by medications. If the patient is on medications and has a low viral load, the risk is much lower. If the person is not on medications, has very advanced HIV, it's much higher. So these are just average risk here. If you have an injection drug user and they share a needle with you, the risk is higher. If you are an infected mother and not on treatment, your baby has a pretty high risk of acquiring HIV, around 20%, 200 cases per 1,000 births. And if you get a blood transfusion, the risk is pretty much that you're going to acquire HIV. Okay, just a word about natural history. This is a complicated slide, but bear with me just a minute here. So people get infected. And then if you look at the red line here, this shows the number of viral particles that can be detected in serum. Now, the virus goes to different parts of the body, but we'll just talk about the plasma here, plasma or serum. And it goes up pretty fast. This is weeks here, and then we go into years. But in the first few weeks, it goes up very high. In this case, 1 million copies of virus in the plasma. This is a typical patient who develops HIV and then goes on to develop a chronic HIV infection. All right, then the immune system kicks in, and the number of viral particles that can be detected drops pretty dramatically, but it doesn't go away. In this case, in this typical scenario, it drops from a million per milliliter of blood down to around 10,000. Okay, this is average. And then it stabilizes. We call this the viral set point. Something about the virus and the immune system, that relationship, there's a set point of quantity of virus in the bloodstream that's different for each person, but it's fairly stable. If you don't treat them, it remains at that level, pretty close to that level for some time. And as years out here, of course, it can increase as one develops more advanced HIV. Now, the immune system is affected by HIV, and that's why people get sick. It's not just the virus floating around, but it's what the virus does to the immune system. And the immune system is the CD4 cells, or the T cells, are the main component of the immune system that's affected by HIV. Most of us in this room probably have around 1,000 CD4 cells per quantity of blood. And what happens is when the virus goes high, it starts destroying these CD4 cells, and they drop. And they can drop quite low. This is a logarithmic scale, so it goes from 1,000 to less than 100. It's not uncommon. Sometimes it doesn't go that low. And then it recovers a little bit, but usually not quite as high as one started out. And then it drops inexorably over time, on average around 50 cells per mil of blood per year. Okay, and then with advanced HIV, you can get quite low CD4 cells and high viral load, and that's what happens with the typical case of HIV if they're not treated. Now, treatment has changed this dramatically. Now, there are long-term non-progressors. Probably less than 10% of patients have HIV, we know, for many years, 10, 15, 20 years, and don't appear to be progressing. Their viral load remains low and their CD4 cell counts remain high. So here's what happens. They're infected, the virus goes up, it's detectable, but it doesn't get as high as 1 million here, it gets up to about 100,000 in this case. And then it drops pretty dramatically back down to undetectable levels. Can't detect it when you do the test. They're infected, we know that, but you cannot detect it by the test for as long out as we can find them. Some people who are considered long-term non-progressors will eventually go in and have progression, but some apparently don't. CD4 cells start out at the level of 1,000, doesn't drop as far down, okay, and then it recovers and it maintains at a pretty normal level. We don't really know why this is the case, but it's probably a function of the immune system. Some people have better immune systems than others, and they recover and they keep the virus in check. And then there's the rapid progressors. What happens here is they get infected. It's either a very virulent virus or the immune system is just not as competent, but they have huge levels of virus here, over 1 million, and the problem is the immune system doesn't reduce that viral load very much. It stays very high here, in this case 100,000 copies per mil for the duration of follow-up here. And the CD4 cells drop dramatically and they stay very low, again, in the absence of therapy. So those are the general categories of patients that we see. Most patients are like the first one. They just have a slow drop in their CD4 cells and a slow rise in their viral load over time. Okay, well, what do we do to treat these patients? So here's the life cycle in a nutshell of HIV. Here's the virus out here in the plasma. It's got its little viral particles inside this capsule here. And what happens is this virus comes along here. Whoops, I should have started with this one. And it binds to a CD4 receptor on the CD4 cells, this immune cell that's floating around in the bloodstream. By binding to this and linking to these co-receptors, which are necessary for the fusion of the virus, it does in fact fuse with the cell membrane of the host cell. This is us right here, okay, and this is them. It fuses here, okay, and it kind of vomits the contents into the host cell, and then the RNA, it's an RNA virus, okay, we're DNA types and these are RNA viruses. The RNA has to convert to DNA to mingle with our DNA, and it uses an enzyme called reverse transcriptase to do that. So it goes from, changes from RNA to DNA, it enters the nucleus of our cells, it combines with our DNA, and then it just produces, it's a factory, it produces more RNA, which leaks out of the nucleus into the cytoplasm of the cell. It combines with, it has enzymes which help it make new viruses, and that's what's happening here. These use the cell membrane to form new viruses. They leave the cell. This is happening. A huge number of viruses enter the cell, and the cell's destroyed in this process. So the CD4 cells drop, and you make lots of viruses. Huge numbers of viruses, billions and billions of viruses on a daily basis. Okay, what do we have for therapy here? You know, back in 1987, I remember going to an infectious disease conference and hearing a report on AZT. It was the first HIV drug. We had nothing before then. We were just trying to treat our patients' infections and doing the best we can and, you know, trying to make them feel better. AZT came along. It was quite exciting. Well, it didn't work very good, but it was a drug, you know, one of the first antiviral drugs. In most cases over the years, we've not had drugs that treat viruses. We have drugs that treat bacteria and fungi, but not viruses. So this is very exciting. Now we have 4 classes of drugs. I'm just going to list them here, and you're not expected to remember them, and don't write a prescription for them just yet, but there's 4 classes. There's the NRTIs, the nucleoside reverse transcriptase inhibitors. They inhibit that reverse transcriptase enzyme. There's non-nucleoside RTIs, there's protease inhibitors, and there's fusion inhibitors, and I'll explain these real briefly on the next few slides here. So here's the same life cycle slide I just showed you. These nucleoside RTIs and non-nucleoside RTIs inhibit the conversion of the viral RNA to DNA, okay? It's not 100%. They don't inhibit all of it, but they greatly reduce the conversion, which slows down the virus doing its dirty work here. And then we've got, not yet, but there are companies working on integrase inhibitors that is necessary for the viral DNA to incorporate itself into the human DNA. We don't have those yet, but they are undergoing clinical trials, so another class of drugs is on the horizon. Then the protease inhibitors work out here as the virus tries to reconstruct itself in making new viruses. Okay, and protease inhibitors are very potent drugs here. And then we've got these fusion inhibitors. We've got a fusion inhibitor that's commercially available and very potent that works here in preventing the fusion of this virus to the host cell. So we've got 4 classes of drugs that act at 3 different sites in the life cycle of the virus. Okay, well, here's 2, 4, 6, 8. We've got 8 nucleoside RTIs. Now, we started out with AZT in the late 80s. Now we've got 8, and there's several more on the horizon. So that's great. You don't have to remember these. We use the codes AZT, 3TC, D4T, and so forth. We don't remember all these other names here, and you don't have to either. And now what's really interesting, long ago, back in the early days of antibiotics, they used to combine antibiotics. We don't do that so much anymore, but now with viral therapy, we know we've got to use combinations of antivirals. If we just use a drug, the virus very easily mutates and develops resistance to that drug. We learned that back in the early days. At least when we had multiple drugs, we found that combinations of drugs did much better than single agents because the virus has to mutate multiple times to be resistant to multiple drugs, whereas it has to mutate once to be resistant to a single drug. It's not quite that simple, but it's something like that. So now, because we use combinations with standard doses, the companies have begun combining drugs. And we have 4 combinations now of these NRTIs. We got Combivir, Epsicon, which just came out, Truvada, and Trizavir is a combination of 3 of these 8 drugs. And again, I'm not going into detail in treatment, but in general, we use 2 of these drugs, or at least one of these combinations here, with one other class of drugs. And the other one class of drugs is the NNRTIs. There's 3 of those. Efavirenz is the most commonly used drug. And so we'd use, say, Combivir, combination of 2 NRTIs, and Efavirenz for a 3-drug cocktail. Okay? The other class of drugs are the protease inhibitors. And there's several of these, 7 here. There's multiple drugs on the horizon, 1 or 2 that's not very far away from commercial use. And these are very potent drugs, and they all have side effects that I'm not going to have time to go into tonight. But again, we usually use one of these, or actually a combination. I'll just tell you the most common combination is lopinavir-ritonavir, which is actually 2 protease inhibitors. But the ritonavir is in very low dose, and it inhibits the metabolism of lopinavir, so it raises the lopinavir concentration. So it's really one drug, but you get high levels of that one drug by the use of 2 drugs. And then we combine that with 2 of the other drugs that I just showed you on the other slide, and so we have a 3-drug combination, really 4-drug combination cocktail for HIV. That's one of the more commonly used regimens. And then we have the fusion inhibitors, and we call this T20 because we can't pronounce the other names of this drug. And this is one of the newest ones. It's synthetic peptide. It has to be given parenterally, so you have to inject it subcutaneously twice a day. Well, that's a pain, so we really don't use this drug up front very often. But in fact, what is known is that these drugs work the best, drugs like this work best when you use them early. But you can't start new patients out on injection therapy. It just doesn't work. We're talking about lifelong therapy until somebody comes up with a cure, the vaccine, or whatever. So we usually reserve T20 for when people fail their other regimens. And we try to combine T20 with another drug to at least get 2 new drugs if they fail other classes of drugs. When do we start treatment? This is a real balance here between starting early and starting later. The pros for starting early would be the earlier you start, the more likely you are to preserve some of the immune system, because if you wait too late, you cannot recover some of the lost immune components of the immune system. The other reasons would be they're more effective when you start early, and part of that's because of the effect on the immune system. The downsides of starting early would be that you have toxicities of treatment. If you start real early with a 3-drug regimen, but before people are at risk for progression, they're going to have a lot of toxicities. And so that's a reason that we often wait till later in the course of HIV. So it's a balance between, well, we're going to lose, how much of the immune system we're going to lose versus the toxicity of the regimen we're trying. Then we have increased risk of resistance. The longer people are on therapy, especially if they miss doses or not totally adherent, then the more likely they're going to have resistance develop. So you don't want to start too early because that gives them a longer period of time to develop resistance. And then, of course, there's the cost of the regimen and so forth. There's a lot of decision points in determining when to start therapy in an HIV-infected person. Now, here's what we base the start time of therapy on. These are data that date back in the 80s before we had good effective therapies. But what was found was that if you start out with an HIV-infected person and look at the time that it takes to progress to a diagnosis of AIDS, and you look at the proportion of people who develop AIDS within a 3-year period, well, it's much higher if the CD4 count is lower, less than 200. Remember, the higher the CD4 cell count, the better is the immune system. When it gets below 200, you start having all sorts of problems. Especially when it gets down in the 50 or lower, you start having really bad problems here. So the rate of progression to AIDS is quite high in this group, and it's much lower if the CD4 count is higher, greater than 350. But it's also related to the viral load. So the higher the viral load, okay, the viral load here, the yellow bars are greater than 30,000 copies per mil, and that's not very high in relation to what I showed you before, but these are the data that we have from the 80s. With a high viral load, the progression rate is much faster than if you have a low viral load, regardless of your CD4 count. So progression is related, is associated with both the height of the viral load or the degree of the viral load and how low the CD4 count is. And we monitor both of those and make therapeutic decisions on both of those. All right, so this slide just shows the viral load curve that I showed you before. Here it goes high, it drops a little bit, and then it stabilizes, and the CD4 count drops a little bit, and then it just kind of gradually drops over time. In 1996, it was thought, look, this is a viral infection, it's a fatal disease, let's treat everybody. So we weren't really sure when to start treating, but we thought, but around that time is when the protease inhibitors came out. We said, we've got good potent therapies, let's treat everybody. But then those other factors weighed in. People were not tolerant of them. We were concerned about resistance. The cost is very high and so forth. And the treatment decisions were modified somewhat. In 2001, people were thinking, well, look, let's treat patients, only those patients who have CD4 count below 500. And then more recently, there's 3 levels of therapy decisions. And very briefly here, the bottom line is, if anyone who's symptomatic with HIV warrants therapy, you've got to treat, because those are the patients who are going to progress most rapidly. If they're asymptomatic and the CD4 count is below 200, you treat. But for the reason I showed you on the previous slide, that the rate of progression to AIDS is very high. If the CD4 count is between 200 and 350, well, most people will treat. But some people say, you know, I think I'll wait a little bit because the patient's not quite ready, and I'm worried they're not going to be adherent and so forth. So some people will treat here, and then when it's above 350, most of us wait these days. Unless the viral load is very high, above 100,000, then we generally will treat. But people differ in that in those thresholds there. Now, adherence is very important. These are data from a trial published a few years ago that show that the rate of failure, and we base failure on what happens to the viral load. With treatment, we expect the viral load to go to undetectable quantities. Starts at 1 million, in a few weeks or a few months, we want to see it undetectable. That's viral, not cure, but that's where we want it to be. If they don't reach undetectable levels, we'll call that failure. Well, the proportion of people who fail is a function of how adherent they are. In fact, this study showed that you had to be greater than 95% adherent to your doses for the best virologic outcome. In fact, if you were 90 to 95%, 80 to 89 here, the rate of failure went up dramatically. So these data, and there are other studies that show similar findings, really hit hard that the patients have to be ready to start therapy. And once a decision is made to start therapy, they've got to stay on their drugs. They've got to take their doses. Over time here, you can just look at the pill burden per day and see how companies, in terms of giving us good combinations of drugs, now clinicians have come up with better regimens to treat HIV. So back in 1996, which is when protease inhibitors became available, here's one regimen. There are other regimens we could talk about here, but this is a 10-pill regimen divided up. You took it 3 times a day, every 8 hours. Okay? Now, there were regimens back in 1996 that were way more than 10 pills. I remember treating a lot of patients with 15 to 20 pills. This is one regimen. And this is in addition to all the other stuff that goes on, pain medications and, you know, who knows what else. In 1998, there was some consolidation here, and we had a 5-pill regimen that you could divide up and take twice a day. In 2002, 3 pills twice a day. 2003, 3 pills once a day. And a lot of these are the same drugs, they're just packaging them in a way that you can take them less often. And now we have combinations that I've shown you before, Truvada and Cystiva, or Epsicon Cystiva, which is a regimen of 2 pills you can take once a day. Now that's not bad, and it's very potent. In fact, the companies that make these 2 pills are now having discussions about combining these 2 drugs so that before long we expect to have 1 pill a day for HIV therapy, which combines 3 very potent antiretroviral drugs. Now, another problem that we're having here, very concerned about, and this is reflected by the New York patient that's been in the paper late, is drug resistance. Well, among treated patients, resistance is very common. Now, I don't really have time to go through all this, but if you start a patient who's newly diagnosed on a multi-drug regimen, chances are they're going to do quite well. Over the course of a few weeks to months, their virus, whatever it was, is likely to be undetectable, and their CD4 count is likely to be going up. Now, it can continue to go up for years. So it may start out at 100, and in a year or two, it may be 200, and then a few years later, it just continues to go up. Not in everybody, but that's what we like to see, and that can happen. But a lot of people, because of whatever reason, sometimes they quit taking their drugs on a regular basis, and sometimes they take their drugs absolutely on time every day, but the virus finds a way because it's replicating, dividing, it's mutating, it finds a way and it breaks through. And if you look at the mutations in that virus, you're going to find mutations to some of the drugs the patient is on. So viral resistance is very common. What's uncommon is to have a new, or has been until recently, it's uncommon to have a new patient, newly diagnosed, never been on therapy before, test that person's virus and to find drug resistance. But in the New York case, that person had drug resistance to the major classes of HIV therapy, even though the patient never been on therapy. That patient acquired a virus from somebody who had been on therapy. Of course, everybody who's newly infected now has acquired the virus from somebody who's been on therapy. And the very fact that they acquire the virus means the virus is highly likely to be drug resistant to multiple drugs. So I think we're going to see a lot more patients just like the patient in New York, at least with the degree of drug resistance. Of course, that patient was a little different because he progressed so rapidly. We usually don't see that combination of drug resistance and rapid progression, but that is something that we're concerned about. Just a word about complications here. Lipodystrophy syndrome is just one of the metabolic complications. High cholesterol, some people develop a metabolic acidosis, diabetes, bone disorders, and so forth. But let me just show you some pictures of lipodystrophy, which is abnormal fat deposition or atrophy. This woman shows several components of this. Atrophy of the face, called facial lipoatrophy, breast enlargement, central adiposity, so big tummy, and thinning of the arms and legs. And a lot of times you can see, you may not notice it, but the patient will tell you, my arms and legs are very thin. Sometimes you see very prominent veins, like you see on this woman here. And that's a function of lipoatrophy, facial lipoatrophy. This is one of the things that bothers HIV patients most. Not everybody gets it, and in fact, it's more highly associated with some of the HIV regimens. When we see this, we try to change their regimen. And then there are injections that we can use. We don't in our clinic, but we refer them on to people who can do this. And there are things that can make this better, but it's quite disfiguring to some people. The venous prominence here in this woman. Some people develop a buffalo hump. We don't like to call it that. It's really a cervical dorsal fat pad, and that's what it is. But some people say, you know, my shirt doesn't button like it used to. They don't even notice anything, but they'll have a fat pad like this. And these are hard to treat, and sometimes they're treated surgically. And lastly, opportunistic infections. This is what people died of back in the days before we had good therapy, and they still do today, but if you're under care and on good antiretroviral therapy and have good control of your virus and on prophylactic medications, the chance of getting an opportunistic infection, an opportunistic infection means an infection that you or I may be exposed to, but we don't get it because our immune system protects us. But if your immune system's not working, you're at risk for developing these kinds of infections. These patients, bacterial pneumonia and TB and herpes and so forth can occur in anyone. So these occur at high CD4 counts. But as the CD4 count drops, HIV patients are at risk for thrush, yeast infections of the mouth, lymphoma, which is a cancer, and Kaposi sarcoma, which is another kind of cancer. PCP, which is one of the most common opportunistic infections in HIV, occur usually when the CD4 count drops below 200. And then you get some infections that do not occur until the immune system is just shot. And these are listed here, and we can talk about them if people have any questions about them. We can prevent these infections by either primary prophylaxis, i.e. giving antibiotics to prevent the infection when the CD4 count is low and they're at high risk. We wait until it's low, so there's no reason to use it before the CD4 gets real low because they're not at much risk for getting the infection. When it drops real low, we put them on antibiotics to prevent these things. Now, heart therapy, antiretroviral therapy, will raise your CD4, so you don't even need to use these things. We don't use prophylaxis nearly as much as we used to because the immune system is in better shape because of our therapies. But here's a list of the infections that we can treat both primarily, i.e. before they've had it, and we can treat secondarily, or that is, they've had the infection, they're treated, but they're at greater risk for a recurrent infection, so we give them secondary prophylaxis. And then just to show you the effect of heart therapy, protease inhibitors came along in 95, 96, and you can see that the incidence of all these major opportunistic infections have dropped dramatically after that. The death rate in HIV has dropped dramatically in those countries where heart therapy has been made available. And lastly, we've come a very long way here. We have a much better understanding of the virus, and you need a good understanding to develop optimal therapies, okay? We have 19 antiretroviral drugs, and more are coming. We've got programs, and Washington State is very generous with our ADAP program. We have programs that allow poor people to access HIV therapy. We have many patients living normal lives, very healthy. You cannot tell that they're HIV infected. There's progress with vaccine development. We have some challenges. We've got this problem with drug-resistant strains, and it's more of a problem today than it was 5 years ago because everybody's treated to some extent. And if you acquire a new infection, and there's around 400 to 500 new infections annually in King County, a lot of those, or most of those, or perhaps all of those, will have some degree of resistance. So that'll make the next batch of patients harder to treat. There's a question of longevity, these salvage regimens. We really don't know how long our regimens are going to last in people, but we know that some people have been on these heart regimens for 10 years now and going strong and doing fine, and maybe that will last a lifetime, at least until something else comes along. Sex and drugs continues to be a problem. Dorothy commented on some of this. It's a problem in HIV. And people are still sexually active even when they're HIV infected, and when they use drugs, it's a bigger mess. We have comorbidities, a lot of mental health issues in HIV, and it makes care very difficult. I won't go into that. We need a vaccine that works. So there's progress, but we don't have a vaccine yet. And we got public apathy, but you're here, so that's good. So we'll keep working on it. So thank you very much.